Thanks everyone for joining the didactic training today. I think this is our fifth one. So we're excited to have Dr. Stephen Wonderlich present today. Just a reminder, we are recording the presentation. It will be available on the Transcend website. And there will be a brief survey that we're going to ask everybody to complete at some point during the end of the presentation. We'd appreciate it if you did that. It helps us try to improve our didactic training series. We're always looking to be a little bit better, and hopefully you'll complete that for us. With that, I'll introduce Dr. Stephen Wonderlich. Dr. Stephen Wonderlich is the interim president for research in Sanford Fargo and the Chester Fritz Distinguished Professor in Psychiatry and Behavioral Sciences at the University of North Dakota School of Medicine and Health Sciences. He currently serves as the PI on the Center for Biobehavioral Mechanisms of Eating Behavior, COBRE, which is currently in phase 1 of funding. He has been continuously funded by NIH for over 25 years and has served as the PI on a variety of R mechanism grants over that time. Additionally, he served as the site PI in the Midwest Regional Postdoctoral Training Program in Eating Disorder Research, which is funded by the National Institute of Mental Health. The bulk of his funded research focuses on eating disorders, obesity, and bariatric surgery. He also served as co-director of the Sanford Eating Disorder and Weight Management Center, which is a broad-based clinic and hospital program for individuals with eating disorders. He also was appointed to the American Psychiatric Association's DSM-5 task force, which created the current diagnostic classification for psychiatric disorders in 2013. I will now turn it over to Dr. Wunderlich for today's presentation titled Basic Behavioral Science to Treatment Development to RCT to Dissemination.
Thank you, Kent. Appreciate you all having me talk today, and I look forward to, hopefully we'll have some time for discussion at the end and any questions or comments you have. The title that I have here is kind of a elaborate title, but I put it in this way because I wanna think about how to go from real basic work to more kind of translational work, ultimately to clinical trial work. And then the complicated step for me, I'm not an implementation scientist, but dissemination of treatments that look good is a complicated deal. And that's probably where I'll finish today because I'm still befuddled by it in many ways. So I'll walk you through this. Our objectives for the day, we're going to look at a particular concept, and that's affective state, emotional tenor in bulimia nervosa. And what do we know about it? Bulimia nervosa we'll talk about in a minute if you're not familiar with the eating disorders. We'll discuss the process of developing new evidence-based treatments in general. And then we'll talk about how do you test them and how do you disseminate such treatments. So a little bit of an overview. Here's the DSM-5 criteria for bulimia nervosa. A few hallmarks. I'm not going to go through it in great detail. It's basically there's the presence of binge eating, which is eating a large amount of food in a discrete period of time. And the person doing it usually reports feeling out of control, compelled, couldn't stop it. It just had to happen. After these kind of eating episodes, people with bulimia nervosa then engage in a variety of different behaviors to try and undo the eating, if you will. Vomiting, laxatives, diuretics, diet pills, enemas, suppositories, exercise, you name it. Anything that gives them the sense that they're somehow undoing this large caloric intake, which older studies in bulimia nervosa suggested that on average, the size of a binge eating episode is about 3,500 kilocalories. Those are in laboratory-based studies. So, I mean, it's not a small amount of food, and it's uncomfortable, and many of them, as we'll get to in a minute here, see down in item D, their self-evaluation is really oriented toward body shape and weight. In spite of the fact that they they wish they were thinner often or pursue thinness, they have these binge eating episodes, which is sort of counter to that aim. We have in the criteria here, you got to have it on item C. You have to have 2 episodes a week for 3 months, or an episode a week for 3 months. And then lastly, you can't have this eating pattern embedded in anorexia nervosa. They've got to be separate things, and sometimes they overlap. So that's just that. So it's basically binging, purging, and a lot of concerns and ideas about shape and weight. The theories of bulimia nervosa, there's a lot. I'm just going to highlight a couple. This is probably the dominant theory. It's been around for a long time. Chris Fairburn at Oxford crafted this back in the early 90s. And his fundamental idea was that people with bulimia nervosa tend to have low self-esteem, which in turn elicits extreme concerns about shape and weight, which in turn promotes strict dieting. Dieting has been shown to be an elicitor, a precipitant of binge eating episodes. And then following the binge eating is self-induced vomiting. And then the reciprocal circles, as you're looking at it on the left, are just saying after it all intensifies, everything stays the same or gets worse. So the process doesn't work in terms of kind of effective outcomes. It's making things worse, ultimately lowering self-esteem through the process of the behaviors. Another model, if you go back to this one, it's kind of weird being in psychiatry, psychology, and like there's nothing there about affective state, mood, depression, anxiety, etc. The closest you get is self-esteem. And some of us always thought, man, doesn't it have something to do with something else? And along came these theories called affect regulation theory. And this is quite different. I'll show you a picture in a minute. Bulimic behaviors in this model are elicited by unpleasant emotional states. Sadness, anger, boredom, whatever. That's what seems in this model triggers the behavior. The bulimic behaviors then occur, and the idea is that they actually reduce the negative emotional state. So, it's got a reward value, and that's what's thought to maintain the process. I feel bad, I binge eat, I feel less bad. That's the fundamental idea. And what you see here is just a diagram of the same thing. Stress of various kinds, interpersonal stress, work stress, academic stress, etc., leads to negative emotional states, which we'll talk about more in a minute, which in turn leads to behaviors like binging, purging, whatever, which in turn then, the loop back reduces the negative affective state. So that's a theoretical idea. I'll get to an empirical test of that in a little bit. So I just propose that maybe emotions have something to do with bulimia nervosa. So that's what we're going to talk about now. But the question is ultimately not only do people with bulimia nervosa have problematic emotional states, but how might that actually figure in to the building, to the mechanistic processes which produce bulimia nervosa? A few basic concepts for the day if you're not familiar with this. Just the whole realm of emotion. What is it? It's a psychobiological system with 4 core components. There's a physiological component to it, like autonomic arousal. There's an expressive component to it. Kind of classically, people look at facial expressions, and there's historically been some idea that each emotional state has a particular kind of physiological pattern, a particular facial expression. Maybe they do, maybe they don't. And then lastly, there is a behavioral response that's associated with given emotional states, which many of us call action tendencies. When you feel sad, you may be more likely to lay in bed. When you feel anxious, you might be more likely to pace. Another couple of terms for the day. Beyond emotional states, there's another term, emotion regulation. Gross said these are things that people do to influence which we have, when we have them, how we experience and express them. Frida said, people not only have emotions, they handle them. And we all have different ways that we manage emotional states. And that's going to come back and be a central component of emotion-based theories and bulimia nervosa. So, is there any evidence that emotion and eating disorders are somehow linked? That people with eating disorders have evidence of more negative emotional states, more dysregulated emotional states, whatever. Is that a possibility that it is associated with eating disorders? The Psychological Bulletin is, I think, the best probably reviewed journal in psychology. Three papers some years ago now thought about this idea, reviewed the literature, and all concluded that there seems to be something important about negative affectivity or emotional states as a risk factor, as a maintenance factor for bulimia nervosa, and that negative states may in fact be increasing before a person engages in the behaviors, which would support, if that was true, the emotion regulation theory that we talked about a little bit ago. So a long time ago, people are saying, yeah, there's something going on here, but we don't really fully understand it. Now, it's one thing to say that people with bulimia nervosa might have more negative affect, more depression, more anxiety, any of these emotional terms. But it's another thing when you start trying to figure out in the daily lives of these people, how might these emotional states operate mechanistically? Because these behaviors, binge eating, purging, etc., as we talked about earlier, they don't happen, once in a lifetime or once a month. They happen quite often. So, like several times a week, many patients in clinics are binging and purging every day. And so, one of the questions is, how do they work? And so, these three items here in the middle are eating disorder behaviors triggered by emotional states? Do eating disorder behaviors modulate, that is, reduce these negative emotional states? And to look at this, we need to do something other than a cross-sectional design where you have people with bulimia nervosa and people without and measure their depressed states. We have to be able to follow them quite intensively in the natural environment and not longitudinality like I assess them once a year. We really wanted to look at them frequently, like multiple times a day. And in order to do that, it takes us into something called ecological momentary assessment, which is where we'll go next. So this is the methodology that we began using to test some of these ideas. So in terms of my title, here we're kind of in the basic translational piece of studying this entity. We're still trying to figure out in nature, do emotional states have anything to do with driving these negative outcomes? So back in the early 90s, yeah, in the 90s, when was that? It was a long time ago. We got a grant from NIH to start doing these studies. And this was the device that we used to do our ecological momentary assessments. And this is called a Palm Pilot for those of you guys who might not remember it. But these were handheld devices, and you could program them to do all sorts of things, ask questions, show pictures. And you can see we programmed ours to let us do self-report questionnaires on the device multiple times a day, every day we did 2 weeks. And so what you see up there on the screen is a questionnaire that's looking at emotional state. You could also ask questions about what behaviors have you done in the last 2 hours? Did you vomit? Did you use laxatives? Did you weigh yourself? Did you skip a meal? What did you do? And so you can see you start to get this real intensive, momentary, daily diary system. We've progressed beyond Palm Pilots, and here at the Center for Biobehavioral Research, which is where I'm sitting, we have something called Retain. And the title of this captures the essence of EMA, Ecological Momentary Assessment, real-time assessment. So in the moment, we do not want to ask you, what did you eat 2 days ago? We want to know, hey, in the last 2 hours, what's been going on? And we want it to be in the natural environment, not a lab. We wanted ecologically friendly findings. Scott Engel heads this program up in our building now and has for some time. And so Retain is an interesting program. If you want to know more about it, just reach out to us. So EMA, it collects data in the real world. It focuses on current or very recent states, events, or behavior. And now we do it. The Retain system is on cell phones. So phone-based assessments are triggered by the occurrence of behaviors. So if you have a binge eating episode and you think about it, please take out your phone and turn this on and record it. But that doesn't happen very often because, after people get done binge eating, it's not like they want to quickly pull out their phone. You can also ask them, hey, before you go to bed at night or when you wake up in the morning, please remember to turn on your phone and answer this. That doesn't work so well. Neither of those options work so well. So what you have to have the phone do is signal the person multiple times a day randomly. And that's how you gather most of the data you're going to gather. So it's real time, it's natural environment, and it is quite longitudinal, and it allows prospective longitudinal tests. So that's actually what I just said. So is there a functional relationship between momentary affect and bulimic behavior? Back in the early 90s, when we started doing this stuff, that was our fundamental question. And one of the first papers that we published looking at this, a colleague who was at NDSU, Josh Smythe, went to Syracuse. He was very into EMA. Ross Crosby, myself, Scott, Jim Mitchell from here in Fargo, and then some other folks from around the country. We all worked on this together. And I'll tell you just a little bit about the study. So this was an NIH funded R01. We had 131 female volunteers, all of whom met criteria for bulimia nervosa. So we bring them in, we do deep dives in terms of interviews and assessments. Their mean age, and then we give them a Palm Pilot and they carry it for 2 weeks. The mean age of this sample, about 25, generally Caucasian. If they had a body weight that was below 85% of ideal, if they had psychosis, developmental disability, I can't see what's behind that because there's a picture there. I don't know what to do with it. Wait a minute. Oh, inability to read, gastric bypass, and medical instability were all exclusion criteria. Now, here's the take home. So these folks carry it for 2 weeks. They're signaled by the device a minimum of 6 times a day, and then they're asked also to complete a rating at the end of the day. We were able to get literally thousands of binge eating and purging episodes recorded on the device by these 131 people. We were also able to get that PANAS, that emotion scale that you saw up there a little bit ago, that was administered to them 6 to 10 times a day, depending on whether or not they went in themselves and recorded. So we had a ton of information about momentary emotional states, and we also knew when they binge ate and when they vomited. because we asked them after they recorded it, we'd say, when did this occur? And we could locate it in time. So then you'll see down at the bottom of this figure, in the center there in the middle, that is when a binge eating episode occurred. And then we fit curves to that, centering it on the binge, but looking back 6 hours before and 6 hours after the behavior. You remember the theory of affect regulation was you should, if the theory is right, you should see increases in negative affect, which then decrease after the behavior. And what you see graphed here in a dark line, a solid line, is negative affect, and the dotted line is positive affect. And it's precisely what the theory predicted, which is in the moments and hours leading up to a binge episode, there's increased negative affectivity, decreased positive affectivity, and after the behavior, somehow miraculously, it reverses, which is the reward process that we posited might be the maintenance mechanism. Why does it continue? Because at some level it works in terms of regulating emotional states. That was the theory. Now, we did 3 large NIH trials using one form or another of ecological momentary assessment, using Palm Pilots, using Retain. We did it in bulimia nervosa. We did a large study, multi-site study in anorexia nervosa, and we did a large study, which was also a treatment trial in binge eating disorder. These EMA data sets, we really wanted to wring out the data. We wanted to know what's going on here because we wanted to understand the essence of this relationship. So we wrote a lot of papers over a 10 to 15 year span trying to clarify that graph that you were just looking at. And I'm just going to run through them. Josh wrote a paper on how to use this EMA in eating disorder research. Tricia Myers, who she's the chair of the eating disorder department in Sanford. She wrote a paper once on a particular form of bulimia nervosa using EMA. The Europeans call it multi-impulsive bulimia nervosa. There's a variety of different impulsive components. She again got the same curve. We started looking at this. Oh, this was Ross. Ross would do these really sophisticated statistical models, just trying to understand daily mood patterns and bulimic behaviors. We started looking at self-harm behavior. Mike Anestis, who was at Mississippi State when he did this, we looked at self-harm behaviors in people with bulimia nervosa, again, trying to use the curve fitting to predict when people are going to cut or burn themselves, for example. We looked at the relationship of post-traumatic stress disorder, and we thought, do bulimic individuals with PTSD differ in terms of their curves than people who don't have PTSD but do have bulimia? And in fact, we found that to be true. What's this one? Then we moved into anorexia. Scott Engel led this paper, starting to look at the curves in anorexia nervosa. It's a little different, but not much. More similar than different to bulimia nervosa. Eddie Selby at Rutgers wrote a nice paper on nothing tastes as good as thin feels, low positive emotion differentiation. And that is, he had this idea that if people can't tell you what they're feeling, they might be more prone to engaging in self-defeating behaviors. It kind of turned out that way. This one, we looked at EMA curves in females who had different periods of time in their menstrual cycle. It looked like that impacted the curves. And then finally, we did some work on dimensional models of emotions, which were very popular at the time. We looked at this, I mean, there were a lot of papers. So, I mean, what we're trying to do there, as any good scientists, we're trying to slice and dice this seeming thing that we found in nature and understand that relationship more thoroughly. because quite frankly, at that point in time, bulimic behavior was not construed in terms of emotions. And so we wanted to clarify. But then some of us were clinically oriented. Now, this is where I want to talk for just a second about translational teams, which I think we need more of up in this part of the world. And what I'm talking about is you get some kind of basic scientist, you get a clinical scientist, you get a data scientist, you get other people sitting around the table, and you try and figure out, okay, what did we just learn here? And what clinical relevance does it have? That's where we got to after a decade of doing this. And so, part 4, if there is a functional relationship between emotions and bulimic behavior, how do you get it to the clinic? Otherwise, it just seemed to us it was kind of spinning. At that time, now we're, moving into the first decade of the 2000s. A couple of people, Jim Mitchell, looked at the treatment we had for bulimia nervosa, said the development of new treatments for bulimia nervosa should be a priority. Terry Wilson at Rutgers said, in spite of the efficacy of evidence-based psychological treatments for bulimia nervosa, the success of even the most potent treatments is limited. So for us, we said, yeah, what could we come up with? What's new? What's different? And so we started working, and this was now people at UND and Sanford, University of Minnesota, and the University of Wisconsin. We had teams at each site, and we started building protocols to treat bulimia nervosa based heavily on what we found in our EMA studies. And so we developed this treatment called Integrative Cognitive Affective Therapy, ICAT. It took us several years. We were pretty focused on it, and we wanted to get it right. We did 3 waves of pilots. A total of 29 people were in our pilot studies. We do 8, 9, 10 at a time. Then we'd look at the data and we'd get patient feedback on what they liked, what they didn't like. And we were doing it in Fargo, Minneapolis, and Madison. And we'd look at this data, and then we'd sit around the table and we'd get scientists, clinicians, data folks, and we'd say, okay, they didn't like this. This didn't seem to work. What should we change? How should we do it? And we kept building new protocols. And then we'd go out and test them again. And finally, I can't remember when, it was in the 2000s sometime, we got an R34 from NIMH to really test ICAT. And I'll talk about that in a minute. And we did that with the University of Minnesota. They were a treatment site. We were a treatment site. The University of Wisconsin was our measurement site, and it was a 3-year study. Our objective was to compare ICAT to an established treatment. And at that point in time, the most empirically supported evidence-based treatment in the world was something called cognitive behavioral therapy enhanced. So that was our comparator. So it was ICAT versus CBTE. We had 80 participants who were randomized to one of the 2 conditions. They were treated either in Fargo or Minneapolis. We put age limits on them, 18 to 55. They could be either DSM-4, bulimia nervosa, meeting that criteria, or we allowed a subthreshold bulimia nervosa, a little less severe, and about 3/4 of our people were full syndrome. We excluded people who were low-weighted, pregnant, lactating, bipolar, psychosis, substance use, were in another treatment, or had serious medical or psychiatric instability. Same kind of profile you see in most things we do up here in eating disorders. People in their 20s, average BMI around 24, 9 out of 10 female, mostly Caucasian. About half were college graduates. As I said, about 3/4 met criteria for full syndrome. This next point, the SCID diagnoses, this tells you something. People with bulimia nervosa have a lot of other problems, mood disorders, anxiety disorders, substance use disorders, as did our samples. About half to 2/3 met criteria for these other psychiatric disorders. So we're bringing people into this trial who usually had 2 or 3 psychiatric disorders that were active. There were no differences across sites or treatments in terms of any of these descriptors. A little bit about the study. It was ICAT and CBT. We had to, it was an NIH trial, had to be time limited. The trend at that point in time was 21 sessions for each treatment. The patients were seen twice a week for the first 2 weeks, and then weekly through the 21 sessions. All of the clinicians in the study were doctoral level, 2 at each site. They all had experience providing CBT in previous trials. We trained them in how to do ICAT. We audio taped everything, was monitored carefully by the University of Wisconsin. We were able to calculate adherence to the protocol, which was very high. Our clinicians did not deviate. Randomization was done by the data center, which was here in Fargo, stratified by site, clinician, and diagnosis. So it was a fairly rigorous, medium-sized trial. Here's a little bit of the outcomes. So ICAT on the left, CBTE on the right. This is attrition. You want to make sure people complete it. And both of the treatments had reasonable attrition, dropout rates 15 to 25%, which is fairly typical for these kind of disorders. Now, this is a measure called the Eating Disorder Examination Binge Eating Scale, and it's telling you the number of objective binge eating episodes at the beginning of treatment on the left. In the middle is at the end of the 21 sessions, and then we did 4-month follow-ups to see if they stayed, better. Because as you can see, there were significant changes in the behaviors over the 21 sessions, and for the most part, they maintained their the changes that they gained through the treatment at 4 months. This is the vomiting. Now, vomiting is a serious medical condition. People purge a lot, getting rid of electrolytes, putting themselves at medical risk. If they're doing laxatives, that's a problem, can cause all sorts of biomedical problems. Interestingly, the treatments both, again, did very well over the course of the treatment and maintained their gains. There were no functional differences between ICAT and CBTE. This is the Eating Disorder Examination Global Score. It's just an overall assessment of their eating disorder psychopathology, same fundamental trajectory, significant improvement, and then stability. Both treatments equal. After that, we did another trial with another disorder, which I'll talk about in a minute. We modified it, but we had good enough results, that were on par with CBTE, which was the most evidence-based treatment at that point in time. We decided to publish the manual, and Guilford Press published it in 2015. We used a variation of it to treat another condition, which I won't go into today, called binge eating disorder. It's one of the core eating disorders in the DSM-5. Carol Peterson from the U of Minnesota led this paper, and we again did a randomized controlled trial. We again found that ICAT treatment for this population worked very well. We found predictors and moderators of treatment outcome, and that's been a reasonable line of work for us as well. So we went from basic science to building a treatment, pilot testing it, to testing it in a couple of RCTs. So we were moving along that basic to translational to clinical line. And then, the question is, so how do you get it out there? there's a lot of people with eating disorders in the world, and we've got this book and data. And the question is, how do you get clinicians to really think about it and use it? And so that's when you get into dissemination and implementation. And we weren't really that kind of researchers, to be frank. So I'm just going to tell you some of what we did, um, and then maybe we'll have some discussion. So after this ICAT thing came out and it looked useful, a lot of clinics, hospitals, professional organizations asked us to give workshops anywhere from 2 hours to 8 hours on how to do it. And we did a lot of those. But then we got into something called learning collaboratives. And that's what I want to focus on, because learning collaboratives basically say, we don't think going to a 2 or a 6 or an 8 hour workshop has much value, because you're just getting a dose of it. And then you go back to, Toledo, Ohio and see your patients. And how do you stay connected to it? Learning collaboratives do intensive workshops followed by usually about 6 months of ongoing consultation and supervision by the trainers for the trainees. We did one in New Zealand. We did one in Portugal. We've done 2 for the Academy for Eating Disorders, large international groups. And I'll show you this and I'll come back. We also did this for a whole different kind of problem here in the state of North Dakota. And we did the learning collaboratives for treatment of trauma and PTSD in children. And we learned a good evidence-based treatment. We got trained up by some people from Allegheny General Hospital. Then we got training teams, and we went out across the state of North Dakota starting in 2006, and it's still going, something called the Treatment Collaborative for Traumatized Youth. When we started, our estimate was that we had less than 5 qualified mental health professionals in the state of North Dakota who could treat these kids. And after doing this for, what is that? I don't know how many years that is, 17 years, 18 years, 19 years, something like that. We have over 800 people who have been through the training in North Dakota. And that's what we wanted to see in our eating disorder work, was something like this. But the learning collaboratives were okay, but I think because they were international, they weren't local, it was hard to manage them. People didn't fully understand it sometimes. And people didn't, frankly, I think, want to spend that much time learning how to do something. They wanted to go to a workshop. So I still think dissemination is challenging. It's cool to come up with ideas, build treatments, test them, and they work. But if we don't get them to the clinics and the hospitals where the patients are, it's incomplete. So I remain frustrated and challenged by dissemination. In conclusion, basic translational research using EMA may elucidate maintenance factors. We think it helped us. Translational teams, scientists, clinician scientists, data scientists can build treatments that target maintenance factors, which could help people to get together to get better. Finally, clinical trials and implementation science may help us to bring our treatments to the patients who need it. That's the end of my presentation.
Okay, we'll open it up for any questions.
Steve, that was a great talk. I really enjoyed it. I've got a couple of quick questions for you. The first is, what do you believe to be the mechanism by which this treatment is efficacious? Do you think that it's a cognitive mechanism? That is, people say, "Oh, this is really bad. I shouldn't do this," or is the mechanism ultimately neurohormonal?
Well, in my world, Gary, if you change emotional states, you're changing neurohormones. You might look at it as neurohormones change emotional states. I think that's true as well. But our goal, the treatment mechanism, was to change the nature of emotion processing in the patients, to make them more aware of emotional states, to help them moderate and regulate emotional states so that they begin to think of other ways to manage them other than perhaps using the bulimic behaviors. So, what we were trying to do was change the emotional world of the patient and help them to find other ways to regulate emotions other than eating disorder behaviors.
I'm just wondering, why not go full throttle on the translation if the ultimate mechanism is mediated by some hormone? I mean, for example, I'm very, let's say the word fearful. I don't like heights. I really don't. Um, I'm not sure that I would be the least bit interested in 20 sessions of people desensitizing me gradually to, being in the Empire State Building, when I might be able to get the same effect by two Ativans.
Yeah, the thing about, using two Ativans is the follow-up studies. Whereas exposure over 21 sessions not only shows improvement, it shows maintenance. Ativan doesn't work so well when you don't take it.
True, but I would take it.
Well, that the longitudinality suggests that people are a little erratic in terms of compliance. I can't see anything. So if there's a
Uh,
question, you're going to have to let me know.
Well, I can chime in here. I have a question.
Sure.
So at the end, you really pointed out that dissemination of these results, trying to get people on board, that's a yet another challenge of getting basic science to actually implementation. What do you think the role of maybe technology would be to maybe improve that? I'm thinking maybe we can't have people go around in person across the state all the time, but maybe we could have maybe more than just a workshop online, but maybe more of a class or, a cohort or something. Do you see using distance technology as a way to maybe not replace some of these more intensive disseminations, but as a supplement to that?
I definitely do, Mark. And a colleague of ours at Drexel University actually took this ICAT and put it into um, a smartphone tablet arrangement so that it could be delivered to them by the phone. And it didn't work out so well because people didn't like the particular program they put into the phone. But the idea, I think, was meaningful. A lot of this, I think, could be done, and there's a lot of good reason to believe that self-help therapies in books, online, etc., have value for at least a subset of patients. I've actually been wondering lately, with some of this AI stuff, which I don't fully understand. I'm too old, Mark, but if there was a way to take a model, a treatment model like we have in ICAT or is in CBTE, and put it into a system that's easily accessible and deliverable in my home at the push of a button, and somebody talks to me and asks me questions like a therapy session, maybe.
uh, that brings us to a question in the chat. The question is, do you think any role artificial intelligence or large language modeling, such as Chat GPT, can do in the eating disorders treatment or intervention? And if it does, what are the challenges? So basically, you were mentioning AI, and that's the question.
Yeah. Um, there was a Chat GPT program that was built for anorexia nervosa, and it came out of WashU. It was clever and innovative, but then it made an error and it started encouraging anorexic individuals who were receiving the program to lose weight. So it made a mistake. So one of the challenges is make sure you don't make a mistake. Um, but I think, and I don't mean to be, you know, really questioning, I think there's real opportunity here. I mean, 48 out of 53 counties in North Dakota are mental health shortage areas. We aren't going to get enough clinicians, even with telemedicine, to treat people all over the state. So I think some of these new technologies, if it can meaningfully communicate and translate the model in a way that makes sense, and avoid errors, why not?
We have another question. What do you think the precipitating event cause is of picking binging or purging as an emotional regulator?
Say that, what, the first part again? What was the what?
What do you think the precipitating event or cause is of picking binging, purging as an emotional regulator?
Yeah, it's an interesting idea. You remember, so it's kind of like, how does a person ever get to the point when I'm feeling sad or I'm angry or I'm bored that I would ever think I'm going to eat a half a gallon of ice cream and 24 cookies? Um, how did I come to that conclusion? And it is a really good question. And sometimes, clinically, when a patient is telling you, I was feeling miserable and then I had a binge, we try and deconstruct that with them and try and understand, how did you get to the idea that eating that would help you with your sadness? And the answer is usually it doesn't make the patients will say, it doesn't make sense. I know that. I just do it. And I do think a lot of these folks have done a lot of dieting, not all, but a lot. And dieting does seem to kind of increase the likelihood of binge eating. So when you're in a really deprived caloric state, your chances of binge eating are higher. And some people might kind of stumble into binge eating through that dietary mechanism, but they might also find out that in some weird way, it helped me to feel a little less bad. And then it becomes a tool. And after it's done a number of times, I think it has the potential to become habitual. And there are models out there about habit models of eating disorder behaviors, and eventually it just becomes a cued response to the environment.
We have another question. Is eating the only thing that some people can control? So that may lead to binging?
I mean, it's an interesting question. Um, I do think there's other things that people can control, and there's lots of ways to control emotional states, and that eating's not the only one. And so that is kind of like going back to Gary's question. One of the things we try and do in this ICAP model is to help people understand more fully what triggers their emotional states, what are their emotional states, and try and use words to describe them. And then finally, what are the ways that I can learn to tolerate, live with, manage my emotional states other than binging, vomiting, or whatever?
Okay. If we don't have any more questions, I would like to thank everybody for attending today. And also thank you to Dr. Wonderlich for your presentation. And also one more thing, one more time, please take some time. I encourage you to take the survey. The link is in the chat. And with that, thanks again, and we will see you on the next one.